All right, folks, welcome back for the conclusion of this lesson on medical exercise knee protocols. We're going to finish up here with the total knee replacement. Now, we put this one last because the total knee replacement is the ultimate management process in managing arthritic knees. This is the last resort. We've done everything conservatively that can be done, and finally it's determined that the client needs a total knee replacement. So they've tried injections, physical therapy, massage therapy, energy therapy, glucosamine, chondroitin, injections, everything. They've even done a couple of arthroscopic procedures. Finally, we get to the point where Mother Nature wins. Mother Nature says, hey, I've come to collect. You know, you've done all these abusive things to your knee over these last 30, 40, 50, 60 years, and bang, here it is. So let me just share a quick story with you about a total knee replacement in a very special person, my mom. My mom had a total knee replacement back in the, I guess it was maybe 2000, 2001. And, you know, mothers are always very special clients, very special. And I say that with all due respect. Mothers are very special in the world. But the funny thing was, I own these physical therapy clinics. My mother would never come see me as a patient. She would see my partner, but she would never see me. And my partner's mother would come see me, but she would never go see him. And it was funny to say this. If you've ever had your mother as a client, it is a very challenging scenario. And again, all due respect to mothers. You got to love mothers. They're vitally important in our society. But the thing I found was my mom had the knee replacement. I was living in California. She had her knee replacement in Washington, D.C. And a good friend of mine, a surgeon at one of the hospitals in Washington, who was a chairman of a orthopedic residency program, did her surgery. And they got along great. She had the surgery. And she had really been putting this surgery off. She just did not want to have it. And she had the surgery. So she had the surgery in Washington. I was in California. I flew home the day after her surgery. So this is at a hospital I worked in. So I was able to go into the hospital after visiting hours are over because I knew some of the administrators and they let me go in to see her. So I get in to see her. She's had the surgery done at this point 2 days earlier. So I get in to see her and she's doing well and she's up on her walker. And the first thing she says to me is, how come you didn't make me have this surgery years ago? Because she was doing so well. And her concern was, once she had the surgery, if anything went wrong, she just couldn't do anything about it. Well, these total knee replacements, folks, for the most part, they're done as almost a standard orthopedic procedure nowadays. But here's what I found out, and this is the important part of the story. So that evening, I'm sitting there talking to her, and I asked her a most profound question. I said, Mom, do you remember when you injured your knee? And she says, sure. Okay. She says, I injured my knee going to catch a softball while I was playing baseball for Edward Waters College. Now, my mother is a graduate of Edward Waters College down in Jacksonville, Florida. It's a tiny little school down there. It's run by the AME Church. So my mom went to this school in her undergraduate years. My mother graduated from college in 1940. Yeah, 1940. So they go down to play a school down in Miami. I believe they went down to play Bethune-Cookman College. Now, this is 1940. So now think about this, 1940. Were there any super highways in 1940? Were they riding on a big Trailways bus, you know, the big luxury bus, going down to play Jackson, down in Miami to play Bethune-Cookman? No, they weren't. They probably had some type of vehicle and, you know, all of them were crammed in. So here's what she tells me. She says, well, I was running to catch the ball. I was the short fielder. First of all, I was floored that my mother even played softball. I had no idea. I was probably in my late 30s. I never knew she played softball. But she was going to catch a ball, and she stepped in a hole. Now, I did that because she steps in a hole with her knee inflection. She says she stepped in this hole because obviously they weren't playing in, you know, Diamondbacks or which Devil Ray Stadium down in Florida. So she steps in this hole, and she says she twisted her knee. And she said on the ride back to the university, over the course of the ride, her knee became more and more swollen. So notice she didn't say it swelled up in the first couple hours. It swelled over the drive back. And probably took about 8 hours to drive back to Jacksonville from Miami at that time because there are no super highways. So it led me to realize that she tore a meniscus back in 1940. And it took some 60 years for the arthritic process to get to the point where it was bad enough that she needed to have a knee replacement. Here's the key thing, folks. All those folks that have arthritic knees that have now had the knees replaced, it started with probably meniscal damage as a result of a trauma, or they just simply wore the thing out. That's the key thing, is that these total knee replacements, they don't just suddenly we need them. Over time, with gravity and just wear and tear, they just occur, or the need for them occurs. So with her, we realized hers started out probably as a meniscal tear. And remember, we said about the meniscus is for the most part what? Avascular. So if it's a meniscal tear, the swelling occurs over a longer period of time. If it's an ACL tear, the swelling would have occurred within the first what? 2 to 4 hours. That's how we know if it's an ACL tear or a meniscal tear. And that meniscal tear over time became more and more arthritic. And the funny thing is, I remember as a boy, my mom's one knee starting to bow more and more and more until actually I finished college, went off, served as an Army officer, came back home, and guess what? Mama now has a knee that's significantly bowed, and she's walking with a bit of a limp, but she doesn't want to have the knee replacement because she's concerned about them putting this thing in her body. Now, if you met her, she would walk into this room and you wouldn't know which knee was replaced. That's how well she's doing. So I just wanted to share that with you because, number one, mothers are special. But number two, this just illustrates all the stuff we've talked about, all does become real and all comes back together. It's a full circle in that she damaged that meniscus years earlier, and just gravity and wear and tear got her to the point of a knee replacement. Does everyone get to the point of a knee replacement? No, but she did. So if you would, the anatomy of the total knee replacement. The femoral condyles are replaced. They're arthritic. The tibial plateau, replaced because it's arthritic. The menisci, this is where it probably started with the menisci. If the tibial plateau is arthritic, the condyles are arthritic, the menisci are probably so chewed up, there's nothing left of them. And that retropatellar surface may or may not have changes in it. If the person is at the point of needing a total knee replacement, would you think that the retropatellar surface would have damage? Now remember, these structures are in the tibiofemoral joint. This guy is in the patellofemoral joint. What do you think? Two separate joints, but would you think this guy also probably has some changes over time? I would bet if they're at the point of needing a total knee replacement, and it's just good old wear and tear along with a trauma decades earlier, probably do. So there's our total knee arthroplasty, or total knee replacement. What they've gone and done is they've taken off the tibial plateau, they put in a new implant, and this is the polyurethane piece, and this is the implant itself. So this is actually acting as the new meniscus. There's my new tibial plateau that's actually embedded in there. We actually drill this out and actually cement this guy in, and there's my new femoral component, or my new femoral condyles. There you go. And notice with this one, there's still a patella. But what you'll find sometimes is if the surgeon checks and sees the retropatellar surface is damaged, he or she's probably going to just go ahead and put a new patella in too. Why leave a damaged piece of tissue in that now has to ride up and down, here's the femoral groove, if it's already damaged? That's still going to produce pain sensations. So they probably in many instances go in, and if that retropatellar surface is damaged, they're going to replace the patella also. So here we go. Take a look at this guy. Anterior view, side view. That's our new knee. That's our prosthesis. And look, there's the hinge. Look right there. That's the hinge. So now I can flex and extend this guy. That's my hinge. Notice I've got new condyles here. I've got a new tibial plateau. Now I still got a tibia here. I still have a femur here, but I've just got new components. I'm good to go. Now think about this. When they went in here, they cut off the femoral condyles. They took off the tibial plateau. So there's significant bleeding? Yeah. And then they put these implants in. In many instances, they'll put this client in what's called a CPM unit, continuous passive range of motion unit. A good friend of mine, Steve Melendez, he's one of our MES instructors. He works with the Chicago Cubs. Steve had a total knee replacement done back on September 5th of last year. This is now March, mid-March 2012. Steve had a total knee replacement done back in September last year. I actually went to Phoenix to help Steve out with this, and I left Phoenix in late October, and Steve was up, around, walking, doing everything necessary. He's now covering spring ball for the Cubs, doing great, no problem at all, same thing. So with these total knee replacements, they can do very, very well if we manage them properly. And Steve's management was, after the surgery was done, vigorously stretching, getting the swelling under control. That becomes vitally important. Getting the swelling under control, stretching, and activating the quad. Please write those three things down. I know you aren't going to see these people after surgery, but write them down. When they have their implant done, first thing we need to do is control the swelling. The quicker we can get the swelling down, the more range of motion we get. So we get swelling down. We get their range of motion back. As we're getting range of motion back, we activate that quad. Which one of those three is more important? They're all equally important. But if I had to pick one, Let's get that swelling down first and continually stick with that theme. Swelling down, range of motion back, recruitment and muscle strengthening. All right? So the pathology of the total knee, it begins with meniscal damage or some trauma someplace. Steve started with an ACL tear with a meniscal tear. It just got worse and worse, and he became more and more unstable. Severe arthritic changes, that's the biggest characteristic. By the time they're ready to have this total knee replacement, they've got such severe arthritic changes, they've lost function. We replace knees, hips, and shoulders, not because the client has pain, not because they lose range of motion or lose strength, it's because they've lost function. So there's severe swelling, pain, and quadricep inhibition. You ever seen someone with an arthritic knee that has a well-developed quad? Doesn't happen. Oxymoron. There's also loss of function. The knee over time becomes malaligned. This is before the knee replacement is done, and the knee becomes unstable too. Okay? Remember, the menisci in the knee are shock absorbers, but they also give the joint a nice congruency. In that, if you can see my knuckles here, and you don't have to zoom in on this, Rich, take your knuckles and fit them together. You know what happens? You get a nice tight fit there. That's what the menisci do in the knee. They give this knee a nice tight fit. Oh, excuse me. And with that nice tight fit, when we tear meniscus or significantly damage, do we now change the fit? Yeah. So now it's not as stable. So what we'll find is that meniscal damage, it has a cascade. And please, if you would make a note here, we call this the degenerative cascade. It starts with meniscal damage, bone spurs, arthritis, swelling, pain, quad inhibition. It's just a vicious cycle until it ends up knee instability, malalignment, loss of function, total knee replacement. The degenerative cascade. All right, there we go. There's our nice healthy knee. Look what happens. This probably started out with meniscal damage, damage to the medial meniscus. Which portion of the meniscus you think was damaged? Anterior horn, lateral horn, posterior horn. And was it a red zone tear or a white zone tear? What do you think? Now, look at this arthritis. Now, you look at this, and these are the stages of arthritis. And this is obviously severe stage. So A, B, C. Okay? So this is our client, say, in his or her mid-20s. They play high school football and basketball or soccer or whatever, and softball, baseball, whatever the case is. They have some minor damage from a meniscal tear when they were a senior in high school. Not a big deal. They played a couple of years of college sports, but then dropped out to devote themselves to academics. Okay? So this is early 20s or mid-20s. Client gets married, has a couple of kids, progresses up in their career, and finally get to the point where now they can take a little bit of a break. They can start, doing more things for themselves. So in their mid to late 30s, they start exercising again. Their arthritis here has progressed. Now, notice the edges of the bone, or the margins of the bone, or the joint, I should say, margins of the joint, we see arthritic changes. Notice the cartilage isn't too bad here, but notice the changes here. So now they start exercising in their late 30s. They're coming to you for an exercise program, and now they try to run, and that knee is a little bit stiff and sore and swollen afterward. Quadricep isn't nice and strong. Okay, you work with them over time, but again, they get promoted or they open their own business, and now they're busy all over again. Okay, they can't come in and exercise, so now they show up and they're now in their early 50s. Okay, they now can come back in, they got more time. Does this sound like somebody you know? This is me. Old injuries, high school playing football, busy building the clinics and everything, and then kind of get started exercising again in my 30s. I start playing golf, all that kind of good stuff. Got some arthritic changes, but at this point, not a big deal. I can handle it, not a problem. I got stuff to do, places to go, people to see. Now I'm in my early 50s. Whoa, that knee now has become more arthritic now. Starting to swell a little bit more. This is that degenerative cascade process we're talking about, folks. This is what happens. Notice the cartilage now is completely worn down. Joint space is narrowed. The subchondral bone is irregular. And now that subchondral bone is exposed, and we now start to see fibrosis in the joint. Well, also, we see exposure here. So with the cartilage, the arthritic development, A, B, and C. Let me ask you a quick question. Who rushes out and buys a case of glucosamine? This guy, late 20s? This guy, late 30s? This guy, early 50s? Because what is the doctor starting to talk to him about here, or her? Hey, you might need a knee replacement. I'm going to go down and buy a case of glucosamine. Hey, man, I'm going to take this stuff because I don't want to have that knee replacement. It's too late. Maybe if I had started back here, but would it have stopped the arthritic process once I had the injury? We don't know. We don't think so, but we don't know for sure. There haven't been any studies. The key thing to understand here is this is a degenerative process. Does everyone that starts here end up there? No. It depends. It depends. For me, because I just kept banging away on my knee, trying to do things I shouldn't have done, like getting up and running a couple of weeks ago, that knee now becomes arthritic. So I got a problem. So hopefully, I'm somewhere between here and here. They may be able to go in arthroscopically and clean my knee up, and now I have to become more responsible. So for me, high impact activities work well for me at this point? No. High compression forces? No. Foot pads in my shoes? Yeah. Okay? So this is just kind of the arthritic process. And my mom went through this and even beyond. Okay? So there's an arthritic knee. Notice with these guys, look at our joint spaces. Very, very minimal joint space. Minimal joint space. Can you see the bone spur right there? You've got this diagram, so if you can't see it here. And notice, virtually no joint space here, no joint space there. Those are arthritic knees. Okay? So here's our normal healthy knee. Look at the nice joint alignment. Everybody in fitness, we talk about the joint alignment. Nice healthy knee, nicely aligned, nice good anatomical structures, looks great. Whoa, what happened? Clients developed some arthritis, some arthritic changes. This probably is, I don't have the malalignment, but probably over the next few years, I may start to get the malalignment. Because my meniscal tear is pretty significant. I've got, on x-ray, I've got some bone spurs. You'll see here in a few moments. Actually, I may have shown you that earlier. So now what happens is, you can see how the knee starts to move into malalignment. This is my mom. As that medial compartment broke down because the meniscus was further deteriorating, notice what happens with the alignment here. This is structural, folks. This is not from muscle weakness, whatever. This is structural. And even if you realign this with exercise, there's still a structural problem here. So now, there are a couple things that can happen. Look what happened here. That to that. What they did what's called a high tibial osteotomy. High tibial osteotomy. What they did, this bone has now started to bow, and we want this, we have this, we want that, and what they've done here is, you notice there's a pin here, okay? That's, I shouldn't say a pin, a staple. What they did, they took a wedge of bone out. You notice the alignment has changed here. Look at this piece, and now what we've done is we've taken a wedge of bone out. We've realigned this. This is called a high tibial osteotomy. They've taken a wedge of bone out, and look what they've done. They realigned this, but look what's here. There still are the arthritic changes here. We can't reverse those. So whether we do this surgically, this is called a high tibial osteotomy, and I know we're talking about total knee replacements. Hold tight for me. Whether we realign this thing with exercise or a surgical procedure, we still have the arthritic changes here. So please, if you would make a note. This surgery that was performed, this high tibial osteotomy, this is sometimes performed as a stopgap measure for the client that doesn't want a total knee replacement, but wants to have something done to realign this knee. This will probably last, how long you think? 2, 3, 4, maybe 5 years? But those arthritic changes are there. And even if we go about realigning the client's knee with exercise, are the arthritic changes there? And for many of you, you say, well, corrective exercise works, and I may say it does, but are the arthritic changes still there? Yes, which means this is going to flare up again, especially on planet Earth where we have gravity. So what we see here then is some clients, though, opt for a total knee replacement. Some clients say, I don't want to have that total knee replacement. My brother or sister or cousin had one and it went bad. Doc, I'll take this high tibial osteotomy. I don't want this. Or someone like my mom finally says, okay, I've done as much as I can. Can't do any more. I need to have this thing done. And please, if you would, make a note. The doctors normally will leave this up to the client. This is elective. This is 100% elective surgery. There's no requirement for this. So by the time the client says, and I remember Dr. Grant, Richard Grant, he's a chairman of orthopedics at a university back east. He says, Mike, when your mom is ready, she'll call me and let me know. And lo and behold, she called me. She says, you know what? I'm going to call Dr. Grant today. I'm going to schedule this surgery because I'm tired of just having pain in my knee. That's it. This is completely elective. So what happens here is they're just simply going to put in a new femoral component, a new tibial component, and look how these guys fit in. There's my new femoral component. We took off the old damaged femoral condyles. Remember, those condyles look like that guy. So we put new condyles in. The tibia looked like that guy. Now remember, this is one compartment that's damaged, but in many instances, both compartments are damaged. So for these clients, we could do this one compartment, just a unilateral replacement or total knee replacement, or we can do both compartments. Depends on the severity of the arthritis. Okay. There is a hinge back here. It's not shown, but there is a hinge here that keeps this mechanism together. So the client just simply flexes and extends the knee. And if you look at this diagram, this is even better. There's our femoral component, there's our tibial component, and look what we have here. We have our new patella. Okay. This patella probably had damage, so the surgeon went in, took off the posterior aspect of that patella, put a new patella cap on. There's my new patella, and this client can now flex and extend that knee. Now, biggest problem for these clients is range of motion. Getting their range of motion back, because this is a pretty involved surgery. We've cut the tibial plateau, we've cut the femoral condyles, we've put new implants in, we've sewn this person up, and the next morning you're up doing what? Walking, and they send a therapist in and they start bending that knee, and I'll tell you, with my mom and both Steve, this was painful. So they get a lot of pain medication here, but we got to get that knee moving as quickly as we can. Number one, because of the bleeding in the joint, and even though we're trying to get the blood out, that blood can get in there and scar. So we want to get them moving as quickly as we possibly can. All right? There's another picture of our implant. Okay, now this one doesn't show the hinge in the back, but there's another implant. And folks, for the most part, this person feels 200% better than they did before. Okay? I tell you, if you ever see Steve Melendez on our website, you see him in course, he'll tell you he felt 200% better after his knee replacement was done. 200% better. So how do we manage these clients? We want to restore and improve range of motion. Now, we want to get their range of motion from 0 degrees of extension, that means full extension, to at least 110, 120 degrees of flexion. We need at least, please write this down, we need 100 degrees of knee flexion for normal human activities. 100 degrees. We don't need 110, 120. And remember, the average human knee has 135. We only need 100 to get out of a chair, get off the toilet, step up on a step. We only need 100. So the implant gives us more than enough. It should give us 110 to 120. So your job as the medical exercise professional is to follow the lead of the therapist and restore or improve their range of motion so it's 0 degrees of extension to 110 to 120 degrees of flexion. Okay? Put an asterisk beside this one. This is your job. This is your major job. If I'm a physical therapist referring this client to me, or referring the client to you, excuse me, not to me. When I refer that client to you, I want this done, more so than anything else. Maintain or restore their range of motion. Don't send them back to me at 90 or less. Vigorously stretch them, because there's nothing in here that can go wrong. If we manage them properly medically, nothing is in there wrong, they're good to go. So strengthen the quads, glutes, and adductors. Activate that vastus medialis. Remember, they've had a surgery. Activate that medialis. Restore their gait mechanics. That means get them walking. Get them up walking as quickly as we can. Use a protocol-based approach. Download the total knee replacement protocol. It's about management, not the exercise. How do we use exercise to improve their function? You've got to make the determination on sets, reps, and rest. We've got the exercises in the protocol. Look at them to determine which one works best for your clients. We have phases in there. The criteria for these clients, minimal swelling. They're going to have swelling the rest of their lives. Please make a note of that. The total knee replacement client will have swelling in that knee probably the rest of his or her life. But it's minimal. Minimal means we can still see the bony contours of what's left over in that knee. We should still be able to see that new patella in there. And as long as we keep the swelling to a minimal, we should be able to get some quad function back, which means these guys may not be able to go out and run the marathons and that kind of stuff, but they're still functional. Medical clearance, full range of motion. Full range of motion, please make a note of this, means when the client comes to you, they should have 0 degrees of extension. They should be able to fully extend the knee and at least flex the knee to 90. Please write that down. 0 degrees of extension, that means full extension and at least 90 degrees of flexion. If they have less than that, and they're months after surgery, usually these people are 12 months after surgery, if they're 12 weeks, not 12 months, if they're 12 weeks post-op, and they can't flex this knee to 90 degrees, something's wrong. That's beyond your ability to manage. So they need to be able to get to at least 90 degrees of knee flexion, okay? And usually it's about 12 weeks, but we're finding with total knee replacements, that 12-week guideline, we're gradually seeing it moving out the door, because with so many total knees done, they normally go to physical therapy for a week or two, maybe a home physical therapy intervention for maybe a couple of weeks, then outpatient PT for a couple of weeks. Normally these folks are usually out and ready for you somewhere between 4 and 6 weeks. Our old guideline was 12 weeks. But if they can flex that knee to 90, fully extend the knee, they're good to go. And Steve, he could get his knee to 90 in about a week or so, well, about a week, 10 days after surgery. So it can be done if the client is vigorous. And you're going to find with these clients, stretching that quad is it is uncomfortable. Oh my God, I had to stretch Steve. And my friend, if you're watching this, I'm sorry that I inflicted that pain on you, but we had to stretch that knee out. And if you saw Steve walking here now, you wouldn't know the difference between wouldn't know which knee would be the one repaired. He's doing great. So you are going to have to work with clients. They are going to have some discomfort. Most of that will be taken care of by the therapist, but you will have to manage some of that. The assessment procedures check range of motion. Obviously, use your goniometer for flexion and extension, quad bulk and strength, vastus medialis recruitment. Use your Lisholm scale to assess their function, and check leg press strength and lateral step-up capability. That means put them on the leg press if you have one. See how much they can leg press, because for these clients, one of the major issues is overall leg strength, and see if they can do that lateral step-up. The reason they had the hip done was so they could go back and do what? Function. See if they can step up. That's one of the biggest issues for total hip replacement, total knee replacements, excuse me. 4 keys: maintain or improve range of motion, strengthen the quad. With the range of motion that you increase, give them strength in that new range of motion. Recruitment of the vastus medialis and overall leg strength. For my mom, that means the ability that she can get out of the chair, she can step up on a step by herself. Okay? Avoid high impact activities. Superimpose strength with range of motion. Look for increased swelling. If increased swelling occurs, it means the exercise is a little bit too much for the client. Back off a little bit, and sustain gains in range of motion. That means if you stretch them today and you increase the range by 5 degrees, give them something to do at home so when they come back the next time, we at least still have 3 or 4 of those degrees. Don't just make it a yo-yo. They increase today, they go home, they lose it. They increase today, they go home and you lose it. Make it such that give them a stretching strap. Show a spouse or someone how to do it. Or they can even come into the studio or into the fitness center when you're not working with them. So they come in to see you Tuesdays and Thursdays. Let them come in on Monday, Wednesdays and just do their stretching exercise. Doesn't help it, doesn't hurt anybody. And if they're a member, let them come in and do it. Just check with them to make sure they're doing all right, because the ultimate is we want a positive functional outcome here. And for these clients, it requires a lot of supervision, a lot of daily exercise. Stretch, 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 stretch. Activate the medialis, strengthen the quads, increase overall leg strength, and remember, the total knee replacement is designed for function. This isn't a thing, well, we don't want you doing anything, Mrs. Smith. My mom is out doing her thing. She's going to church. She's going to see her friends. For a while there, it's like I never knew what a woman was. She was always gone and out of town, which means the total knee replacement works. So please, if you would, don't baby these clients. Push them, get them going. As they get more strength, fine. And the other thing has to do with assistive devices. Now, my mom, if you ever meet her, she carries a cane, really nice cane. You know, one of those with the little sculptured head and everything. And my mom does not need that cane. But she carries her cane every place. And I know when I go to Washington, I take her to dinner. We go out to dinner, and it's every time we go to dinner, we're out in the parking lot getting ready to get in the car. She says, oh, I forgot my cane. Which means, does she really need it? No, it's just a psychological thing. To say this, you as the medical exercise professional, you should not tell the client to use or not use their cane, crutch, or walker. That's up to the doctor, therapist, or chiropractor. Now, I'm a physical therapist, been one for 27 years, and I've told my mom a million times, you don't need the cane. But to her, it's just that little psychological crutch. And if it were really a problem that I could see that she didn't have the function necessary, I would say, hey, Mom, we really need to send you back to the doctor about this. But I think she knows she doesn't need to use it, but it's just one of those things that now she just takes along with her. She can walk around, climb the stairs, do whatever she wants with no problem. But it's just that issue of that cane is just part of the psychological process with her. So to say this, you're going to get clients that are going to have canes, crutches, and walkers when they come to you. Let the doctors, therapists, and chiropractors determine when they need to discard those. You, though, work with the idea of getting them to discontinue the use of those structures or those pieces of equipment. Also, with regard to 4 key exercises, vigorously stretch the quads and the hams, leg press and leg step-up activities, because we want to get them more functional with closed chain activities. Standing terminal knee extension is excellent. And lastly, biking. The reason biking, getting on that bike and going around range of motion is vitally important in restoring full range of motion for knee flexion and also full range of motion for knee extension. So this becomes a key thing along the way. These exercises are vitally important in helping these clients restore their normal level of function. So it becomes vitally important. So again here, these are just 4 key exercises. We have a number that are noted in the protocol. You determine which ones work for you based on the equipment you have, based on your client's needs. But the bottom line is we want to improve their overall leg strength. We want to restore their level of function. And remember, the total knee replacement was done with the idea they should be able to be fully functional as quickly as possible. Okay? So again, managing clients with lower extremity disorders, particularly knee disorders, you're going to find overall leg strength becomes important. PFS is always lurking somewhere around the knee. And again, when we see a swollen knee, we see a knee where that vastus medialis isn't working well or isn't recruiting well, we know in 85% of the people that will be the case. So start looking at these clients from the standpoint of individually, yes, but globally, yes. The average client has an underdeveloped medialis. Along with that, when they have swelling in the knee, we know it's going to inhibit their quad, and they're now on the fast track to PFS. In our on-site courses, I'll tell you, most of the clients come in with a big beacon on their forehead that says PFS. No, they don't. They don't come in like that. But if you understand what's going on with them pathologically and biomechanically, when they come in and tell you, or you see that medialis isn't working, they have low-grade swelling, there should now, from your standpoint, you should see a blinking light on their forehead that says PFS, PFS, PFS. So the best way to manage PFS is to do it before it needs to be managed, or get involved and get in front of it before it needs to be managed. Okay? All right. Download the quiz, complete the quiz for this segment, and we'll see you in our next lesson. So thanks for joining us.